With 20 plus years as a physician, a CMO, and a medical director, I've watched health systems spend millions on strategic initiatives that quietly fail because of one thing nobody wants to name. It's not a cultural problem. It's not a physician engagement problem. It's a structural problem. And it's measurable, diagnosable, and fixable. Here are 10 things I wish every health system leader understood about. If you're leading a health system, an ACO, Medicare Advantage plan, or a hospital or independent medical group, stay with me because at least 3 of these are going to apply to your organization right now. Let's get into it. Number 1, misalignment is a cost driver, not just a cultural issue. When physicians and operational leaders aren't aligned, it shows up in unnecessary utilization, avoidable readmissions, and failed care protocols, all of which carry a direct dollar amount. It will equate to millions of dollars in unnecessary patient spend in ACOs that can be tracked directly back to alignment gaps. In one ACO, it was $54 million, not a soft metric, a line item. Number 2, most physicians aren't resistant. They're uninformed. The physician who won't cooperate is usually one who was never given the operational context behind the ask. When you show a physician how their clinical decisions affect total cost of care at the panel level, behaviors change. Without that context, you're asking them to follow rules they didn't help write and don't understand. Number 3, your best physician leaders may be your biggest alignment risk. High-performing physicians are often given operational titles without the infrastructure to succeed. They carry dual loyalties to their clinical peers and to administration. And without clear authority or support, they default to appeasement instead of accountability. That's not a character flaw, that's a structural flaw. Number 4, CMS star ratings and leapfrog grades don't move without aligned physicians. Quality metrics are downstream clinical behavior, and clinical behavior is downstream of alignment. I've seen a health system move from a 3-star to a 4-star rating and maintain a leapfrog grade A, not through a quality program, but by rebuilding the physician operational relationship first. Number 5, physician engagement scores measure the symptom, not the disease. A 78% physician engagement score sounds strong until you ask what's actually driving it. Engagement measures how physicians feel. Alignment measures whether clinical and operational priorities are actually integrated. You can have high engagement and still be hemorrhaging margin on misaligned care protocols. 6, payer relationships suffer when physicians aren't aligned with value-based contracts. I've recovered over $5 million in payer underpayments for a single health system, not through contract renegotiations, but through closing the gap between what the contract required and what physicians were actually documenting and delivering. The money was there, the alignment wasn't. Number 7, ED utilization is an alignment problem disguised as a capacity problem. When primary care physicians aren't aligned with population health goals, patients default to the emergency department. I've helped reduce emergency department utilization by 10% in 6 months, not by adding capacity, but by aligning physician behavior with the care management infrastructure that was already in place. Number 8, physician recruitment without alignment infrastructure is a liability, not an asset. Recruiting 18 providers in 18 months means nothing if you're bringing them into a system where the operational model doesn't support their clinical goals. New physicians can read the culture in the first 90 days. If alignment is broken, they either leave or they adapt to the dysfunction. Number 9, the alignment gap is always diagnosable before it becomes a crisis. There are leading indicators: rising physician administrative friction, declining quality metric trends, increasing variation in care protocols, deteriorating payer performance, that show up 12 to 18 months before the board starts asking hard questions. Both health systems aren't looking for them until it's expensive to fix. And finally, number 10, you can't solve an alignment problem with a physician wellness program. Wellness initiatives are valuable. They don't fix structural misalignment. When physicians feel that operational decisions are made without their input, the strategic initiatives land without clinical context. No amount of meditation apps or catered lunches closes the gap. Structure, communication, and accountability frameworks do. 10 things, every one of them grounded in actual work, not theory. If any of these landed differently than you expected, that's usually a signal worth paying attention to. I built Ordavia Healthcare Solutions specifically to help systems identify where alignment is breaking down and what it's costing them, before it shows up in your quality scores, your payer contracts, or your board report. If you're a health system leader wondering whether alignment is the hidden variable in your performance gaps, I'd welcome a 20-minute conversation. Drop a comment or message me directly. I read and respond to everyone. I'm Dr. Tony Liazzo, the guy with the bow tie. This is Ordavia.